So I wanted to start, I know there are a lot of young families here and a lot of families with new babies. And so I wanted to start with two stories. And I want you to hear the stories because they're written by the children. And I wanted you to realize just how awesome the kids are growing up nowadays and how fabulous and smart they are. So this is Jillian. Jillian lives in Chicago. And Jillian wrote this story when she was 12. She's now 17, going to go to college next year. And this is what she wrote. And this is her own story she wrote, not her parents. I asked. On the outside, I look like a regular kid, but on the inside, I have a huge secret. It affects everything in my life, my behavior, my emotions, the way I learn, think, and grow. The most challenging part is the food that controls me. I'm 12 years old now, and there's still no solution for this horrible disability. Without a cure, food haunts me every day. As a result, I feel angry, frustrated, and sad. Sometimes because I can't have the food I want, I cry or steal it, even though I know it's wrong. I thought that was really insightful and profound for a 12-year-old to be able to say that. This is Rachel. Rachel lives in Virginia. This is her high school graduation, and she's in college now. And when she was a junior in high school in biology class, they had to write an essay about something. And she wrote about Prader-Willi, and she called it My Secret Life. I have a copy of it in my office. And she said, I want to tell you about my secret life. And she was standing in front of the class when she gave this presentation. Most of you know me as Rachel, the straight-A student, but I was born with a genetic condition called Prader-Willi syndrome. Because of it, internally, I struggle all the time. Because there's no cure for PWS, it's a constant struggle for me to make and keep friends. It's hard for me to keep a conversation going, to look people in the eye, and I'm not interested in what others are talking about. My emotions control me every day. I can be very emotional. I cry, whine, scream, yell, repeat myself over and over again. I want a life that isn't controlled by food, exercise, and emotions. I'm counting on researchers to continue to work hard to try to make my life better. And so again, I say those things not because they're not, perfect. They are suffering, from the afflictions with Prader-Willi. But I think that the wording and how they say it is so profound and so insightful for people. And I remember when I started this, people said, oh, people with Prader-Willi have no insight. They've got no empathy. And you can see that that's not true at all. So I am going to start with a brief appetite review. Hannah's going to go after me, and she's going to talk about diet stuff. So I'm not going to talk about diet. And then we're going to do some brief medical issues and then research. So first, appetite. So those of you who see me have heard me talk about this. Those of you who don't may have heard this as well. These are the nutritional phases that we identified back in 2011, looking through about 20 years of retrospective data on individuals with Prader-Willi syndrome. And we identified 7 different nutritional phases. Phase 0 is in utero with the decreased fetal movements. They actually are born typically about 15% smaller for both weight and length than unaffected siblings. And then phase 1A is the hypotonia with difficulty feeding. This is the need for the G-tube or the NG tube or widening the nipple of the bottle to feed the baby. They may also have failure to thrive, even with enough calories. And as you all know from experience, they often don't, or typically don't want to eat. They don't cry for food. They don't get excited for food. And then somewhere around 3 to 9 months or so, they go into what we call phase 1B, where they stop having difficulty feeding and they're growing just fine. And then at around 2, so 18 months to 3 years of age, they go into phase 2A, and that is weight gain without a change in calories. So those of you who have kids in the 2 to 3 year old age range will recognize this phase where they just start to gain weight and you've changed nothing, and all of a sudden they're gaining weight. And they really don't have any increased interest in food at this time. They don't really care. They're just gaining weight more easily. And then phase 2B happens around 4 to 5 years of age, and that is when they have an increased interest and awareness of food. So they're still satiable. They still will push food away if they don't like it, but they are very interested in food. What are we going to have for dinner? When are we going to have dinner? When are you going to cook dinner? Are you sure you're going to cook dinner? Well, especially if they're off their routine. And this phase is associated, which Elizabeth may talk about as well, with an increase in anxiety, sort of a general anxiety sort of starts at this age. And then phase 3 is your classic phase that you read about with Prader-Willi, where they are hyperphagic and rarely feel full. and that lasts through adulthood. And then some individuals, albeit a very small number, will go into what we call phase 4. And that's where the appetite goes back down again. So they've been in phase 3, they've been insatiable, and now the appetite drops back down to what I think is comparable to phase 2B. So they're still aware of food, they're still interested in food, but they can be satiated again. Again, this is a very few number. I recognized your boys, Matt, sitting there. I was like, God, those are Matt's kids. They look just like you. Sorry, personal. All right, so this starts in childhood, and it starts as early, often as 15 or 18 months. And the reason it starts is because how many of your kids drink plain water? Almost nobody, right? I mean, that's lucky, because most do not. You saw no other hands in this room. Most kids hate plain water with Prader-Willi syndrome. The hormone that controls the salt-water balance is abnormal. They don't want plain water, and so to get them to drink so they don't become dehydrated, what do you as parents do? You flavor it. You put something in it. You put a drop of juice. You put a little splash of the, low-calorie chocolate, or whatever it is. You do something to flavor it. Well, that's when this all starts. So if it tastes sweet on your tongue, for any of us, it drives this vicious cycle. It's just more profound in Prader-Willi even than in the rest of us. So anything that tastes sweet on your tongue will then cause your brain to release dopamine. Dopamine is an addictive neurochemical, so it makes you addicted to the taste of the sweet. And it also causes insulin release from your pancreas, and that causes immediate fat storage. So at 18 months, 2 years of age, and people come in and they say, I don't understand why my kid's gaining weight, Hannah and I start asking them questions, and it's always, well, what do they drink? Water. Plain water? Well, water with a splash of juice, and it's just a splash, but that starts the cycle, okay? So as soon as you're triggering that insulin release and that dopamine release, you're not only promoting weight gain, but you're promoting addiction to sweet substances. With the insulin release, insulin drops your blood sugar. That's what it does. And so your blood sugar goes down, and when you have a lower blood sugar, your appetite goes up. Your body is designed to preserve your blood sugar in a normal range. So when your appetite is low, or when your blood sugar is low, your appetite goes up. So this starts the increased appetite, okay? So it's a vicious cycle that just continues. So every time, as parents, that you give your kids, a little bit of, but it's the, low-fat Hershey syrup, or it's, it triggers this cycle. And I know it's hard to get kids to drink plain water with Prader-Willi, and Hannah's going to talk a little bit more about options that we have, but this is the cycle that starts the whole process. This is what we saw in phase 2A, and this is how we know this is what's happening. So we were doing a natural history study at University of Florida, Vanderbilt, Kansas, and UC Irvine. And we looked at individuals with Prader-Willi syndrome, their siblings, and then also kids with early onset obesity that had no Prader-Willi syndrome. And kids with early onset obesity develop what we call insulin resistance. So that insulin surge from the pancreas is really high when they have sweet in their mouth. Whether it's artificial sweetener or real sweetener, doesn't matter. The sweet taste drives the insulin release, which drives excess weight gain. And so you see that, and that's in the sort of pinky orange color over there, that they had this huge insulin release when we gave them sugar. Look at the kids with Prader-Willi. It's almost the same. These are thin and normal weight kids with Prader-Willi. These are not obese individuals with Prader-Willi. These are normal weight kids with Prader-Willi. So even if you can keep the weight normal by restricting calories or restricting food, you still see this huge insulin surge in response to something sweet. So what influences our appetite? Well, there's a lot of things, obviously, that influence our appetite. In Prader-Willi, as with all of us, social situations obviously play a role. You're at a party, everyone's eating, you get hungry, somebody's eating in front of you, you're interested, you want to eat. Stress is a big one. A lot of us are stress eaters, myself included, and so stress will increase your appetite. Remember, I said that in phase 2B, you get a generalized anxiety. When you've got increased anxiety, your body perceives that as stress, and that causes an increased appetite. Timing and rhythm of eating also influences your appetite significantly. So we used to tell families all the time, we want you to be on a schedule. We want you to say 8 o'clock is breakfast, 12 o'clock is lunch, 5 o'clock is dinner. And what we found is that by doing that and setting that time, that the body becomes adjusted to it. And you all who've done that know that at 4:55, your kid's going, it's dinner time. It's almost 5 o'clock. It's dinner time. 5 o'clock is dinner time. What are we doing? And so we know that setting that schedule is not necessarily the right thing to do for a child with Prader-Willi syndrome, because that timing sets you up for the future. And then, of course, hedonics. Hedonics is the love of eating, the desire, the pleasure. And that's a big one in Prader-Willi, again, because of the sweet thing. So again, we've driven dopamine up in response to anything that tastes sweet in our mouth. And so every time they eat, it is like getting a hit of cocaine anytime they have something sweet. That's hedonics. So there's also homeostatic influences. Those are influences that come from the body. And there's a lot of signals that come from both the body fat as well as the gut in typical people to signal us to stop eating. In Prader-Willi syndrome, these pathways are broken. They don't signal the brain the way that they're supposed to. And so you don't get the normal satiety signals going from the gut or the fat tissue up to the brain to tell you to stop eating. So not only do you have all these things up at the top that are driving the appetite up, you've got the things at the bottom that are not working. So as a result, the appetite becomes insatiable. This is just a picture I always like to show, and those of you who have heard me talk before have seen this picture because it's my favorite. And this is to show you a PET scan of how someone with Prader-Willi syndrome responds to sugar. And this shows you a normal brain, a brain of someone who's a cocaine addict looking at pictures of cocaine, and then someone with Prader-Willi looking at pictures of sugar, stuff with sugar like candy bars and stuff like that. And what do you see? It's addiction. They are addicted to the sweet taste. And we know that the reason this is important is because weight control is important. So this is from the natural history study again. We looked at IQ during the natural history study, and we looked at the influences of weight, diet, growth hormone, everything that we could think of. And what you see in the bottom here, the littlest bar, is historical. The average IQ of adults with Prader-Willi is 63 in the literature. And so if you look at those who were treated with growth hormone and had good weight control, their IQ is almost equal to that of the SIBs. Okay, so it's normal. Those who are on growth hormone with poor weight control, so those who became obese early and stayed obese, have a lower IQ, still higher than the natural history, so still higher with them without growth hormone, but nonetheless lower than we would want it to be. All right, I'm going to move on to medical. I'll have questions at the end if that's okay. All right. So endocrine issues, my favorite. The most important issues are endocrine issues. As you probably know, children with Prader-Willi syndrome have about an 80 to 85% prevalence of growth hormone deficiency. Somebody's screaming back there. Is that yours? So it's not everybody by any means. However, what the studies have shown is that even if you don't have true growth hormone deficiency, if you've got Prader-Willi syndrome, you benefit from growth hormone therapy. So in multiple ways, including IQ, Elizabeth Reif and Elizabeth Dykins just published a paper on this about a year ago, showing IQ improvement with growth hormone therapy regardless of your growth hormone status, whether or not you were growth hormone deficient before you started. And it's been published in the Netherlands as well, and as well as muscle mass, muscle tone, and stamina. So we recommend that everybody be treated with growth hormone. Of course, the dose has to be individualized for the person, but that there is a benefit to treating with growth hormone regardless of your initial growth hormone status. Only 8 to 50% of adults, however, meet criteria for growth hormone deficiency. The reason for this is that growth hormone deficiency criteria become much more strict when you're an adult. Who cares? We care in the United States because the insurance cuts you off as soon as you're done growing. So as soon as your child is done growing on growth hormone and the bones are fused, they say, you're done with growth hormone. And so we care because we want adults to be treated, because it doesn't matter what this number is, that's 8 or 50%, it doesn't really matter. Again, the studies have shown that there are benefits to using growth hormone regardless of whether or not you're growth hormone deficient. You just have to titrate the dose appropriately for the person. So you or I could take growth hormone, guess what? we have normal growth hormone, we would still benefit from growth hormone, okay? Think Arnold Schwarzenegger, Sylvester Stallone, so we all would benefit from growth hormone. It's not gonna hurt anybody, well, unless you take too much of it. But we want our adults to be able to stay on growth hormone. And so the problem is, because there are so few adults that actually meet criteria for growth hormone deficiency, it's very, very difficult to get it continued and approved in the United States. Hypogonadism, so delayed puberty, undescended testes, ovarian or testicular failure, present in about 87% of individuals with Prader-Willi syndrome. So I'm sure when your children were born, you were told there's no chance of them having children, they're going to be infertile. That is not entirely correct. There are some individuals with Prader-Willi syndrome who have normal gonadal function, go through puberty completely normally, and are potentially able to have children. So it's about 87%. Central hypothyroidism, about 15% of adults, 20 to 25% of children. The reason central hypothyroidism is important is because a lot of doctors will check what's called a TSH, thyroid stimulating hormone. That's how they check thyroid function. You say, I want my kid's thyroid function checked, you check a TSH. Well, with central hypothyroidism, what happens is your TSH is normal, but it can't get high enough if you need more to keep the free T4, the active thyroid hormone in your blood, normal. So you get a normal TSH, but guess what? The thyroid hormone that you're actually using in your blood, not normal, too low. And that actually impacts brain development, it impacts weight, it impacts stamina. And so I try to make a point to tell parents this is a different kind of hypothyroidism. You need to tell your doctor it's a different kind of hypothyroidism so that they know to check all the labs so that they can figure out what the problem is. And then central adrenal insufficiency, which is the most scary because this is the one that can be associated with sudden death. Adrenal crisis or adrenal insufficiency causes low blood pressure, low blood sugar, and can cause death during an illness. It's about 10% from the numbers. You'll read that it's anywhere from 0 to 60%, just depending on the study that's been done. The problem is the testing for central adrenal insufficiency is crappy, and so you just don't get any kind of consistent numbers. There's not, unfortunately, a great way to test your child when they're a newborn or when they're a baby and say, your kid's going to have issues. And so we just have to be aware that it's about 10%, and I'll talk on the next slide about what we do about it. Hypoglycemia, much more common than we ever thought. We never looked for hypoglycemia in babies with Prader-Willi syndrome. And the reason we never looked was they didn't have symptoms. So typical babies with hypoglycemia have seizures, okay? Or they're waking up all the time to feed. So in glycogen storage disease, do the babies sleep through the night because of hypoglycemia? No. They're waking up every hour to two to feed or whatever. They never sleep through the night. Our kids will sleep through anything, right? And so we don't know if hypoglycemia is present in them. I have been in the hospital with a kid who had a blood sugar of 26 while taking cognitive testing and said, I don't feel very good. And we checked her, she had type 1 diabetes to be fair, but we checked her blood sugar and it was 26. You or I would be on the floor with a seizure at a blood sugar of 26. She was just fine. I mean, she wasn't fine, but she felt bad, but she wasn't, there was no symptoms. So we have to watch. This is one thing that we watch very carefully. And then diabetes can be present, especially with obesity, in about 20 to 25%. So thyroid. So to go back to the central hypothyroidism issue, I recommend that until age 3 that people have their endocrinologist check the thyroid function at least twice a year. The reason for that is because it most commonly begins in Prader-Willi syndrome between the ages of 1 and 3. And because the weight gain can start at age 2, people go, oh, well, the weight gain, it's Prader-Willi syndrome, and you just attribute it to that. But the weight gain can also be a sign of low thyroid function, or the excess sleepiness, that's just Prader-Willi syndrome. Well, the excess sleepiness can also be a sign of low thyroid function. So we want to check it at least twice a year. After that, usually you can check it annually because the kids after 3 are able to tell you if they don't feel good usually, and so you can space out the checking. Adrenal issues. If the child has anything that makes you suspicious for adrenal insufficiency, I point at you because we've had this discussion, I believe. No, maybe. So frequent illnesses, sicknesses that are out of proportion to the illness, so they get a cold, but they end up dehydrated, lethargic, not able to take oral intake, they get hospitalized a lot, or they need surgery, we want to check for adrenal insufficiency. The easiest screen is to do an 8 a.m. cortisol, has to be done by 8 a.m., no later than 8 a.m., because cortisol peaks at about 4 a.m. in the morning, so it's already starting to go down by 8. If you get it after 8, it's going to be invalid because the standards are for 8 a.m. The problem is most of the time when we check this, it ends up in a sort of middle range that we're like, we don't really know what to do with this, So we just often will treat with what we call stress dose hydrocortisone, giving the stress dose of the hormone that's there during illnesses or hospitalizations or surgeries or whatever. Because the testing is not great. The STIM testing that we can do, it exists, endocrinologists do it. It's not great. Growth hormone screws it up. Supplements can screw it up. I mean, there's just a lot of stuff that can mess up the results of that STIM testing, and so it's just not a great test. Gonads, of course, puberty and infancy. In infancy, we can give the baby boys medicines to help their penile growth, their testes descend, their scrotal sac improve in size, and we can also do that during puberty if we need to. In girls, unfortunately, everyone's like, can't we just give them some of that hormone that makes those little boys so much stronger? And no, because we don't want facial hair on our girls, and so we can't. But in adolescence is when we address it with girls, and so if we need to, we can give them estrogen in puberty. Again, not everyone needs it. Blood sugars, if anyone is concerned, you want to check the blood sugars and know that this should be something that's on your radar if you have an infant with Prader-Willi syndrome. So when I am concerned about checking blood sugars in a baby, it's because the baby, either they're sleeping through the night in what I think is way too young of an age, so they're sleeping all the way through the night at like 2 months of age. That's concerning to me. I think that's too long, and I'm worried that their blood sugars are going to drop during that time. And so, or if people are worried about maybe my kid is having seizures, or they're spacing out some of the time, I'll ask people to check a blood sugar. And then after age 10, we actually flip the other way and start looking for diabetes, so higher blood sugars. So after age 10, we check an A1C, which is a measure of your blood glucose over the past 3 months, at least once a year, to make sure that there's no diabetes there. The thing is, growth hormone raises blood glucose. We think that because growth hormone raises blood glucose, this is one of the reasons why giving growth hormone in infancy helps the IQ. Because you won't get as much hypoglycemia during infancy if you're treating the baby with growth hormone. But after age 10, especially if you start to gain weight, which the most common age to start to gain weight is high school, when food is more available and there's less supervision, then that growth hormone raising the blood sugar can be a negative, okay, because it can actually push you into type 2 diabetes if you're at risk. And then growth hormone. And I'm just going to say growth hormone. What questions do you guys have? Think of them, and we'll come back to it because, I'm sure there are probably some. But I'm not going to give specific recommendations for specific children, but if you have questions about growth hormone, I'm happy to answer. All right, pulmonary issues. As you know, individuals with Prader-Willi have sleep-disordered breathing. It can be obstructive sleep apnea. It can be central sleep apnea. It can be what we call hypopneas, which is shallow breathing. The current recommendation is that you get a sleep study before you start growth hormone therapy and about 8 to 12 weeks after you've been on growth hormone therapy. And then a lot of doctors are nervous and continue to do sleep studies every year thereafter while the child is on growth hormone. My problem with that is those of you who have 2- and 3-year-olds, think about sticking them in the sleep lab with all that crap all over their head and the cannula and the monitor. It sucks. So unless there's a reason to do a sleep study, I do not recommend repeating the sleep study just for the sake of repeating the sleep study. Just because the endocrinologist feels like, well, I just want to be safe. If your kid's not having any problems, I don't think there's necessarily a need to do this, okay? Now, if your kid is having problems, such as increased daytime sleepiness, snoring at night, pauses in breathing when they're sleeping, lots of nighttime awakening. There are kids that wake up 3, 4, or 5 times a night and go visit mom and dad in their bedroom, or new onset behavioral problems. These are when you need a sleep study. So if you email me and say, my 4-year-old boy is having behavioral problems, I think he's just being a 4-year-old boy, my first answer to you is going to be, go get a sleep study, because behavioral problems are a very common manifestation of fatigue. okay? And so, and especially boys, it tends to be overlooked. I use boys as an example because people are like, boys are boys, they're hitting, they're slapping, No, it could be that they're really tired and that's why they're more irritable. Things that can disrupt sleep include low blood sugar. So this is one of the reasons why we'll check blood sugar sometimes if the parent will say, my kid is starting to wake up at 2 a.m. every night and I don't know why. Or my favorite, which I'm sure some of you has experienced, my kid is waking up at 4 a.m. every morning and won't go back to bed and then falls asleep in the car on the way to school. That can be low blood sugar. So the first thing we ask you to do as we're scheduling the sleep study is to check blood sugars and see if the blood sugars are dropping during the night. Low iron levels can also do this. Low iron levels give you what's called restless legs, so you're a very disruptive sleeper, and that will wake you up if you're a child, often as an adult too. But if your child is very restless, I will suggest to you that you get iron levels checked. And then the other interesting thing is that artificial sweeteners have recently been shown to disrupt sleep cycles, which I thought was very interesting. I know. And the reason I think it's interesting is because a lot of parents doing very specific diets will do something called, a fat bomb that has like an artificial sweetener in it or some sort of sweetener in it. And that actually may disrupt the child's sleep pattern. So not a good idea to do. Central sleep apnea, no matter what the age when it occurs, it typically responds well to low flow oxygen during sleep. We are seeing central sleep apnea more and more commonly in like 2 and 3-year-olds, and we're not sure why, what the impetus is for this. I am convinced it's something we're doing, whether it's diet or something like that, but we haven't been able to figure it out. So if you do have a kid that has central sleep apnea on their sleep study, and they'll say to you, your kid needs CPAP. If you've ever tried to put CPAP on a 3-year-old, it's like, I don't know, getting a cat in a dress or something, it's just ridiculous, so it's not going to happen. And so, my pulmonologist will call other pulmonologists and be like, hey, guess what? You can take this 3-year-old home and put CPAP on them, and you let us know when you fix that problem with the CPAP, and you can give them back to their parents, because it's impossible. CPAP blows air in your airway. It's really uncomfortable if you're not used to it. I've tried CPAP on before. It makes me feel like I'm suffocating. I can't imagine putting it on a kid and trying to explain to them, you need to wear this every night. So low flow oxygen works. Now, they're often going to take it off. You'll usually find a 3 or 4-year-old with oxygen to the eyeballs in the morning because they've pulled it out of their nose, but it works to help the central sleep apnea, and it's so much more tolerable than CPAP that this is what we typically recommend. But every sleep study I read says CPAP for central sleep apnea, and I send it to my pulmonologist, and she's like, no. Yeah. So in infants and young children, the most common thing we see is what's called obstructive hypopneas. So when your kid has a sleep study, they have a ton of obstructive events during the sleep study, and the doctor says, oh my God, they've got obstructive sleep apnea, go to ENT. Well, guess what? Your tonsils aren't there until you're about 15 months old. So sending a 3-month-old to ENT is going to do you absolutely no good at all, because they don't have tonsils and adenoids for ENT to take out. And the ENT will go, I don't know, there's no tonsils and adenoids there. And it's usually due to reflux. Okay, so reflux, when they reflux up, it hits the vocal cords, slams them shut, and causes you to breathe a little bit more shallowly for a few minutes until it goes back down again. Kids with Prader-Willi, that have older kids know, their reflux is often silent. You don't see it. They don't projectile vomit across the room like other kids do. And so you don't often know that the kid is having reflux. And so if you see that pattern on sleep study, the first thing is usually reflux. Obstructive sleep apnea in babies and young kids can also be due to a floppy airway. So just because they don't have enough strength and tone to keep their airway open if they're laying on their back. So what you see is that the kid will often flip to their side or flip to their back or to their stomach, and that's how they sleep at your house. But guess what? In the sleep study, you have to sleep on your back. And so they put them on their back, and then they have all this obstructive sleep apnea. Well, at home, they don't have that same amount of obstructive sleep apnea because they're not sleeping in that position. Their bodies are smart enough to know to flip them, and so what we say is, evaluate them by ENT if they're a little bit older and have tonsil and adenoid tissue, but chances are this is what it is, and they just actually need growth hormone to fix this rather than have to wait on growth hormone because they have obstructive sleep apnea. So again, a lot of doctors will view any kind of sleep apnea as a contraindication to growth hormone, and that is indeed not the case. So if your kid has this, the chances of them getting better with growth hormone therapy are really good. The most common cause of death in Prader-Willi syndrome of any age is still respiratory failure. This is with or without growth hormone therapy, and we don't know why. We don't know if it's, aspiration, if it's, we don't know why. But we do know that this is still the most common cause of death, and so it needs further investigation, because one of the things that we worry about most is respiratory illnesses, the flu, RSV. Those are things that we worry about, especially with growth hormone therapy. Is it going to cause any problems or not? And we just don't know the answer to this question. So we're looking into this, and people who know more about respiratory stuff than I do are looking into this. But I make people aware that it has, in general, nothing to do with growth hormone therapy, the respiratory problems. It is actually just something intrinsic to Prader-Willi, probably the low muscle tone, that they can't get up those thickened secretions, and they get into trouble. Orthopedics, I always get asked, even though I'm not an orthopedist, and so I take this from Harold Van Bossy. When should we get our first x-ray done? Harold recommends that you get your first x-ray done when your child can get from a lying to a sitting position on their own. So not that they can, sit up if you prop them up, but they can sit up from laying down. That's when he wants the first x-ray. And the reason for that is that if you have scoliosis before that, you're not going to do anything about it. Because if you put a kid that can't sit up in a brace or a cast, they're not going to sit up. And so we don't want to do that. We don't want to impede their development. And so we don't do, the global we, Harold, doesn't do anything until they can actually sit up on their own. In children under 5, as you all probably know at this point, casting is now recommended for a curve over 27 degrees to help correct the scoliosis. Bracing still recommended from 20 to 27 degrees. And the casting procedure is that, they put the kid under anesthesia. The scoliosis is rotational as well as an S-curve like you see here. So they put them under anesthesia, they derotate them, and they pull, and then they cast them just like that for 3 months at a time. It's not a fun procedure. They're under anesthesia though, but I saw it, made me kind of sick. And then the other thing that I really, really recommend for young kids especially is hippotherapy, which is horseback riding therapy. This can do wonders for scoliosis, and also anything that you can do to strengthen the core muscles. One of my biggest problems with the casting and the bracing is that the kids with Prader-Willi will lean on the cast or the brace because they can. It's there, it's right under their arms, and it will support them, and so they lean on it. That's not, although it is fixing the scoliosis from a physical perspective, it's really not doing anything to prevent it from coming back again, because their core muscles are still weak under there. And so I hate that. So as soon as they are in a brace rather than a cast, I say, take that brace off, stick them on a horse. Take that brace off, physiotape them. Take it off, do karate or taekwondo or something like that. So anything you can do to strengthen the core muscles will help to prevent the scoliosis from coming back or worsening again. Ophthalmology, many individuals with Prader-Willi have crust eyes or strabismus. Some can be corrected with patching or glasses, and some require surgery. At the beginning, when we first started treating babies with growth hormone therapy back in 2000, I said, oh, well, this is going to fix that strabismus problem because it's due to weak muscles. And so if we put them on growth hormone, their muscles will get stronger and we won't have this problem. Didn't happen. It helps a little, but it doesn't fix it. And so some still do require surgery. Kids with Prader-Willi are still kids and can have other eye problems, not just the weak muscle tone due to Prader-Willi. I actually recommend that every child be seen by an ophthalmologist annually for an exam of their eyes because, again, they can have other issues. Kids with deletion type of Prader-Willi in particular can have hypopigmentation of the optic nerve, which can cause problems as they get older, so it needs to be evaluated and watched for. GI issues, this is, again, not me, this is from Ann Scheinman, constipation, as you probably are all aware, is a super duper common problem in Prader-Willi. Most of your kids probably suffer from it in some way, shape, or form, and it can cause bowel obstructions, which can be very dangerous. There are several upcoming studies that Ann wanted me to say, that there are going to be studies to evaluate the effects of specific probiotics that can help with gut motility. There are going to be studies to evaluate the gut microbiome in Prader-Willi as compared to the siblings to see what's different and how can we replace what's abnormal or change what's abnormal. And then we're going to do a study evaluating fiber in Prader-Willi syndrome, an insoluble fiber, so it doesn't cause gas, to see if that will move the stools along a little bit better. One of the things that we've found in all ages of children with Prader-Willi is their fiber intake is really, and excuse this, I don't mean it to be a pun, but it's crap. They don't eat enough fiber because if they're adults, they're on low-calorie diets often, and so to keep their calories low, their fruits and vegetables will be iceberg lettuce because there's no calories, and you can eat a lot of that and you don't get a lot of calories. As kids, a lot of kids are on a low carbohydrate diet. A low carbohydrate diet is very low in fiber, and so we think that there's a benefit to having fiber in your diet, and we know there's a benefit to having fiber in your diet. It brings down cholesterol, and it also can help with gastric motility. And then, as you probably are all aware as well, you can have delayed gastric emptying. This picture just shows how big the stomach is. The stomach should be like a third of that size, and this is just a kid that got an x-ray for her back, and the mom brought Hannah and I this in clinic and showed it to us, and we were like, oh my God, that's a huge stomach. I mean, they're huge stomachs, and so they get this enlarged stomach. It's just Rachel. So, sorry, my dad's in the hospital, so Hannah's holding my phone in case. Sorry. Well, I get it on here. And so with this enlarged stomach, the walls of the stomach can get thinner, and so it can be more easily perforated, which can lead to gastric necrosis if they get into too much food, or they don't chew and swallow food well and end up with a lot of whole food in their stomach. Skin picking typically becomes common when kids enter the insatiable appetite phase, so when they are more hungry, the skin picking ramps up. We often see it ramp up in phase 2B in sort of a more minor way, so they'll start to pick, nails, hands, lips, because of the anxiety, and then as they get more and more hungry, they can develop these big lesions that they pick, which won't heal for quite a while. We have kids that have lesions for many years. These are very extreme examples, obviously, and we don't really see this bad, but I mean, it can happen for sure. One of the things that we use to help with the skin picking is something called N-acetylcysteine. N-acetylcysteine is it's an antioxidant that works in the glutamatergic system in the brain, and so what it does is it changes the reward reinforcement pathway. So it decreases the rewards you get from doing a compulsive activity. So they're doing a lot of research with N-acetylcysteine on things like compulsive gambling, addiction, and so in Prader-Willi, we found that it can decrease the skin picking. I know. But it usually doesn't completely get rid of it, but it can decrease it, which is important. And so people are like, but they still have, it helps. The problem with N-acetylcysteine is it oxidizes very easily when it's exposed to air, the pills that you get for N-acetylcysteine at the health food store. So if you get a big bottle of N-acetylcysteine and you start opening it up every day to give it to your child, by the time you're about a third of the way through the bottle, you're giving them nothing, because by the time it's oxidized, it becomes ineffective, and so it's not doing anything. So we recommend that you get an individually packaged form of N-acetylcysteine to keep it from being exposed to air until you're ready to use it. There's multiple ways to do this. There are some products that are available prepackaged. Pharmanac is one of them. The problem is that those products, because we recommend them to lots of people, are often out of stock. So you're on it, your kid's doing well, and then you go to buy it on Amazon and it's gone, for 3 months or whatever. The other way to do it is to find a compounding pharmacy and ask them to blister pack the pills of the N-acetylcysteine for you so that they're sealed and they're not exposed to oxygen until you use them. All right. Research. Oxytocin, as you know, my baby. And so oxytocin is known to be important for control of feeding behaviors. It's also the love hormone, the bonding hormone. And so the initial studies on oxytocin and Prader-Willi syndrome happened in the MAGEL2 deficient mouse, which is a mouse model of Prader-Willi syndrome. And it showed these mice initially had 100% lethality as babies because they wouldn't eat, just like babies with Prader-Willi syndrome won't eat. And you can't get enough food through a teeny tiny mouse NG tube to keep them alive, and so they would die. Giving them a single injection of oxytocin actually saved them, and so it made them feed better. So the person who did this study was named Francoise Muscatelli. She worked right down the hall from my friend Dr. Taubert, who's a pediatric endocrinologist in France. she told her this data, and Dr. Taubert started to do studies in babies. And so there are studies that show some varying results. The studies in the babies, she just published the first study in babies. It was a single to double dose of oxytocin given either once period, or once a day for like 5 days, and or twice a day for 5 days. And what she found is that even once a day for 5 days, intranasally, the oxytocin rescued the neonatal feeding. So it allowed them to feed normally by mouth rather than needing the NG tube or the G tube. This is very exciting stuff. It was not a placebo-controlled trial. Needs to be redone to prove that it to prove that it really works. And so because, the question, of course, is always, well, how do you know that developmentally that kid wasn't going to start to feed that week anyway, because it happens, and so it needs to be redone, which we are going to do very soon. And but it was very exciting stuff. The most exciting to me was to watch the babies feeding with their mothers. So the videos, the mom's feeding the baby the first day. The baby is a typical baby with Prader-Willi syndrome. Eyes closed, not looking at mom. Very difficult to bond as you're trying to give this baby this bottle and you're trying to force the issue. And after a week of oxytocin, the baby's eyes are open, looking at mom. Dad walks into the room. The baby turns to his voice. I mean, it was really pretty incredible to watch. And so I'm very hopeful that doing this study will make a difference in the lives of those babies yet to come with Prader-Willi syndrome. Dr. Taubert also did a single-dose study in adults where she found an improvement in social responsiveness and potentially an improvement in appetite after one dose of intranasal oxytocin. She just completed a trial in adults, which was a 6-week trial of different doses of oxytocin in adults in France, and she's analyzing that data right now. Stuart Einfeld, who's an autism researcher in Australia, subsequently after Mate published this first adult study, did a study of adolescents and adults with intranasal oxytocin. She used a single dose of 24 IUs one time in this initial adult study. He used a dose of 24 IUs twice a day to start with and then ramped it up if there was no response, and found that indeed when you ramp it up, you get worsening behaviors. Now, oxytocin is an interesting hormone. I won't bore you with all the details about oxytocin, but suffice it to say that it's not a clean hormone. It binds to other receptors. And if you overdose it and bind up all the receptors, then what happens is it binds to other receptors, which cause behavioral problems, paranoid behaviors, temper tantrums, things like that. That's what we think happened, was that it was just an overdose effect. So the initial dose was high enough that it not only bound the oxytocin receptors, but probably equally bound these other receptors. And then as he ramped the dose up, it bound more of those other receptors because the oxytocin receptors were already all bound up. So you got no effect, or you got a negative effect. So way too high of dosing, which taught us something very critical, which is that the dosing of this hormone is extremely important. And then we just finally published our study, which we found improvement in anxiety, compulsive behaviors, and appetite with low-dose oxytocin for 1 week in kids 5 to 11 years of age. So carbetocin is actually being developed right now. Carbetocin was initially developed by a company called Ferring Pharmaceuticals. Elizabeth Roof and I did the initial study with carbetocin. We were very thrilled with the results because it is not, it is receptor selective. So oxytocin is not. It can bind to other receptors. Carbetocin only binds to the oxytocin receptors. So it can't be overdosed, which is very exciting. And so what we saw was even with 3 times the dose that we were giving of carbetocin versus oxytocin, we were seeing really positive results in terms of anxiety, behaviors, appetite. And so one of the moms actually has started a company. Sarah Cotter is her name, and her company is Levo Therapeutics. And she is initiating development of carbetocin for studies in Prader-Willi syndrome later this year. Diazoxide, I don't remember the name of the new company. Oh, Capnia. Diazoxide is a treatment that we've used forever in endocrinology. We use it for treatment of high insulin levels to keep kids from having hypoglycemia. And so it's been around for forever. And the thought of diazoxide is that not that in Prader-Willi syndrome, not that we will protect from the hypoglycemia, but rather that it's going to remember I showed you that signaling defect from the gut to the brain? The thought is that by giving diazoxide, you may be able to bypass that block in the signaling problem from the gut to the brain and compensate for those signals that are not getting to the brain adequately in Prader-Willi syndrome. And so Capnia is the new company. It's changed names like 3 times. And they are gearing up to start their phase 3 in Prader-Willi summer 2017. So coming soon. Setmelanotide is a melanocortin-4 receptor agonist. It is something, melanocortin-4 receptors are a receptor that's involved in feeding regulation. So if you activate the melanocortin-4 receptor, you actually induce satiety or feeling full. And the idea behind this drug is that you give it so that it activates this receptor and makes you feel, it triggers the satiety pathway in the brain so that you feel more full. It actually is also involved in body weight regulation by affecting metabolism. So the hope was that by giving this drug, you would not only affect satiety, but also potentially increase metabolism, which would be fabulous. And so it has been completed now. I don't remember how many patients. 32? Yeah, so, and we finished the study, and the results are being analyzed right now. So we don't know the results yet, but just a little tempting piece. At the International Prader-Willi Conference in Toronto this year, the Elise Pharmaceuticals presented data from their first trial of a drug that's called AZP-531. It will have a very complicated name very soon, I am sure. This is an unacylated ghrelin analog. So to me, ghrelin is kind of a confusing hormone, so I always explain it this way. So active ghrelin is your hunger hormone. That's the one that makes you more hungry. Unactive ghrelin, the unacylated ghrelin, is antagonistic to that. So it actually prevents the active ghrelin from making you more hungry. It also increases your sensitivity to insulin, increases metabolism, and can have a protective effect on muscles that are exposed to low oxygen levels. So Elise Pharmaceuticals developed this drug, which should theoretically block the active ghrelin as well as increase metabolism and help the muscles. And the trial was done in France, and they found some improvement with food-related behaviors in adults with Prader-Willi based on the hyperphagia questionnaire, primarily was their outcome measure. The results were exciting, and so they are in phase 3 development right now for their next trial, which will be done both in the US and in Europe. Cannabidiol, CBD oil, I get asked about a lot because it's an anxiety thing. I'm sure Elizabeth gets asked about it 20,000 times more than I do. And so CBD is a derivative of cannabis, obviously, but without the high properties of cannabis. And so one of the companies called Insys is interested in looking at CBD. Their thought is that if you give it, everyone always thinks cannabis, you get more hungry, right? The idea here is that if you give this twice a day, you actually turn down the dopamine response to food, and so that it would actually decrease appetite by giving cannabidiol twice a day. And so they're looking at appetite and anxiety with this medication, and it's scheduled to start this summer still, as far as I last know. And this is interesting. One of the things that they asked me to say to parents is you can buy cannabidiol online, but when they tested the products that were available online, all of them that they tested had 0 actual cannabidiol in them. So if you're spending a lot of money on cannabidiol online, you may not be getting anything, just to warn you. And if you have decreased anxiety, it could be a placebo effect or it could be real. There may be some, but when they tested all of the products that they tested, I think it was like 26, had 0 of all the ones that you could buy. So, the bottom line I wanted to tell you, in terms of what's new in Prader-Willi is that your kids are going to be successful. They're going to do great. They're going to do what every other kid in this world does, and be public speakers or run races or play sports or whatever. And I just wanted to tell you, the adults, did not have the benefits that your younger kids have. And those of you who have children that are adults know this, that unfortunately they didn't have the early growth hormone treatment. It wasn't known about, and often diagnosis was much later. So I just wanted to give you a little bit of inspiration that despite those hurdles of not having what your children have had, I wanted to tell you a couple of inspirational stories. My favorite is Elise. She's 22. She is at Radford College in Virginia. She lives about 50 miles from her parents in an apartment by herself. She goes out to eat. She does her thing. She's majoring in early education. She'll graduate. She's a junior this year in college and doing very well. She was most upset because she gained 20 pounds when she went away to college and when I explained to her that we all gain 20 pounds when we go away to college, she didn't accept that because she's not supposed to gain weight. But so, and she says, it's really hard to not gain weight when you're eating out. And I'm like, and that is why we all gain 20 pounds when we go away to college. So she's doing very well. Nicole is age 24. She graduated college last year. She is working in Miami as an ABA therapist. Her mom lives about an hour and a half from her. Both of these individuals drive. They come to visit me in their own cars, and and she works with kids with autism and loves to tell me the stories of what she's gotten a kid with autism to do that day, with her therapy. Noah is another 24-year-old. He did not go to college, but he graduated high school with honors on his diploma. Took 3 AP classes his senior year and 1 his junior year. He owns his own woodworking business. And if you go online on Etsy, he has these incredible puzzles that he makes out of wood, and he sells them to raise money for Prader-Willi research. He's very, very talented. And there are more stories like this, and I'm sure you all know somebody, or have read about somebody who's being successful. These are my personal patients that I know well and have known for many years, so I like to share the stories because I think it's important that that your kids have even more advantages and more opportunities to be this successful as they grow up. And that is all. I'm done. Questions?